Okay, thank you. So, good evening, all the delegates and members who are watching this amazing webinar. So, today we have planned it under the UPSOS meeting, which is specially to help you and to guide you by the mentors regarding your complications. Whenever you are doing your surgery and you face something related to cataract crisis or glaucoma crisis, you have mentors to tell you how to deal with that particular situation, and that is why this webinar is named as Crisis to Control. And we have wonderful faculty lined up with wonderful expert panel who will guide you in such crisis situation and what can you do and what not to do. So, uh, first of all, I will request President Dr. Shashank Kumar to welcome the delegates, and then we will start with the webinar. Dr. Shashank, sir.
Good evening, everybody. Just you're getting my voice?
Yes, you're audible, sir.
Yes, sir.
Good evening. Today's webinar is organized by UPSOS. All are welcome to this webinar. And let's start. I think out of the how many people have joined this?
I think all the faculty and expert panel has joined. Few of them will join later who are traveling. So,
Okay.
has Dr. Abhishek Chandra joined?
And see his name, Shalini, in
Can't see.
the
Okay.
list of participants.
Fine. So, first talk we will be having by a wonderful glaucoma speaker, Dr. Shweta Tripathi. She is an excellent surgeon, wonderful orator, and fantastic academician. So, Dr. Shweta, she is from Lucknow, we all already know. We will request you to present your video, and this will be followed by expert opinion from Dr. Mukesh, who is glaucoma expert from CL Gupta Eye Institute, Muradabad. He is very specific about his training given to optometrists and technicians and also to various fellows. So we will be having his expert opinion and then we will be having discussion. So Dr. Shweta has chosen a very pertinent topic, which is about fibrosis of or scarring of bleb, which is the most common cause of bleb failure. So let's see how what she has to tell you about the management of bleb failure. Dr. Shweta Tripathi.
Yes, thank you, ma'am. Thank you for the kind words. And before I start the presentation, I'm just going to share my slide. So, in the lieu of that, I would like to thank the entire UPS SOS, including Shashank sir, ma'am, and Dr. Abhishek, Dr. Deepak, for having me here as a part of this academic feast, as you very correctly said. So, my topic today is a battle against the scarring. And the first point would be that whenever we talk about a perfect glaucoma surgery, so glaucoma surgeries till we get an ideal bleb. My voice is echoing. Is it okay to everyone?
Right now, okay. Just a few seconds back, it was echoing. Right.
So when we talk about the trabeculectomy, ever since its emergence from 1968, it's been as a gold standard for glaucoma, especially when we talk about the advanced damages or to control the fluctuating pressures. And these kind of blebs, these kind of eyes, I'm sure that it is not uncommon to each of us sitting here. So now after that, to keep all those things in mind, the move field safe surgery system was introduced in the field of glaucoma surgery, which to a higher extent prevented the occurrence of the hypotony or the leaking blebs. But still, there was certain more to it. Because when we talk about an ideal bleb, it should not look like this. It has a low cystic, low lying bleb, reduced vascularization and cystic changes, the picture shown on the left. Then what is the cause for this kind of bleb failures? The most common cause is always going to be, as said, scarring. And how do we prevent it? And how do we get an ideal bleb? So it's early recognition of the signs. So now if we talk about this case one, where this was a young male with the baseline pressures of 50 and 54, advanced cupping, we performed trabeculectomy for the case, and the IOP was maintained in mid-teens till 5 months post-op, till we started getting a picture like this and the pressure shooting up to 30 millimeters of mercury. We knew that there is encysted bleb which is underlying, and it was not responding again to the medications. So all we thought was to perform a bleb excision. So now here what we did is, first with the help of a spatula, the portion which was covering the cornea, the blunt dissection was done. Now we came back again and we thought that, okay, before we go and excise the actual tenons part, like a simple needling procedure with a 26 gauge bent needle, the scarred area was freed from all the surroundings. Basically, the encysted made area and even the conjunctiva, because we knew that the end we have to advance the conjunctiva and suture it down. So this is how it was all freed, and the scarred tissue was snipped off from 360 degrees of that surrounding plane. Now, if you see, after doing this is a I can say amalgam of needling along with the snipping of the tissues. Now, with this, we started doing the bleb excision, because now we have freed the superior conjunctiva, the underlying tissue is freed, and you see that how clearly we are undermining it with the help of a blunt dissection. Now, every time we undermine, we make the tissue free. Again, we take the excessive part of the bleb and we keep on excising step by step. Mind you, it has to be in a very phasic and slow manner, because otherwise suddenly the sclera may rupture and give you the way. So after I felt that I was in the correct plane, the leak was further checked with the help of a fluorescein dye, and a suture 10-0, though it was no leakage was there, still a augmented suture of 10-0 was made. And again further, if you see, after burying, again the leak was checked, and you see I'm pulling the conjunctiva and suturing the conjunctiva over the scarred area with the help of a 8-0 Vicryl. Now again, when I put one suture, now again with the help of a blunt spatula, again I'm freeing the conjunctiva, because in these kind of eyes, the conjunctiva is very frail, very fragile. So the minute you put any kind of tensile strength to it, there is a liability of the conjunctiva to break down and cause leakage further in future. So this is the bleb excision. Post-op 2 weeks 12, and the patient came to me last month and still he's maintaining the pressures of 15. And this is again a case operated somewhere else, came with a totally flat bleb with high pressures. And why I kept this point here was, though needling I've shown in the previous video, but here in my needling cases, I never take a superior rectus bridal suture. I go for a 8-0 Vicryl kind of traction suture on the cornea. The needling is performed in a similar precarious way. And at the end, if you see here, we give the injection of 5-fluorouracil, and ideally it is done with a 30-gauge needle, so the suturing is not required. But here I had put one Vicryl suture just to close and see that there is no leakage of the wound. So here we had put the sutures, and that's how the patient is maintaining the pressures as well. So now furthermore, if you see in your OPDs, low bleb, high pressures, initially what I start doing is give a gentle massage. This is a same bleb where you see that post massage, the bleb is elevated with the pressures under good control. Now one more help in the OPDs we get with the help of a 5-fuse which you give, and you see that immediately the vascularization is reduced, and you call the patient after 1 week and titrate your 5-FU doses accordingly. So at the end, I would like to say that the trabeculectomy still remains the mainstay in the glaucoma surgeon's armamentarium, and careful surgical technique, close post-operative monitoring, and anticipatory and aggressive management can help patients achieve the safe outcomes and long-term control of the IOP. Thank you very much.
It's very
Thank you
excellent.
so much, Dr. Shweta. That was an excellent presentation and a very great technique. Yes, Dr. Mukesh, we will request your expert opinion.
Yeah, thank you, Shali madam. Dr. Shweta, excellent management of this case. Because I understand the resident doctor, they are also attending this webinar. So I like to make a comment here for all those who are learning trabeculectomy and those who are watching this webinar. always remember to repeat your gonioscopy before doing any management of any failing blab, because sometimes it is also possible that you are dealing with a case of a case where there is a blockage of ostium also. So the blab needling is always beneficial when you are combining the case with the agent like 5-FU or mitomycin C. Definitely, we are going to increase the survival of your surgical repeat procedure with the combination. And this is also important to understand when the failing blab is happening, the duration, how much after the surgery are we dealing with a recent case or dealing with a old case of trabeculectomy surgery. So the time when the patient present, it is also important to understand, and it is also important to understand when we repeat the procedure and when we do the needling also. So needling most of the time is the within a month procedure, but also helpful in the old case also. Not always like when you are doing in the early 1 month cases, but also helpful in the old cases also. But I always recommend for old cases or the cases who are 1 month older, don't forget to repeat your gonioscopy before doing any bleb needling or before doing any kind of surgical intervention, because sometimes there is a blockage of ostium also. And for the scarring, definitely Dr. Shweta already presented an excellent management video. So I like to congratulate Dr. Shweta for this excellent effort. So I like to conclude here.
Yeah, just one addition to what I said in my presentation, what Dr. Mukesh also emphasized to the residents here, that always look for the encystment and the early sign of recognition. Because what the bleb where I excised, no, the bleb, the patient was not responding to the 4 medical therapies, and then I went ahead and did the excision. So that should not be the first choice of treatment for your cases. And encysted blebs initially only, sometimes they do respond very well with a simple beta blocker medication as well. So that's very important. And gonioscopy, yes, of course, as emphasized by Dr. Mukesh, it's really important. Before you go for any surgical intervention, please make sure in your OPDs that diagnostically you are pakka that what diagnosis you are making.
Yeah, sure.
Also, the initial few weeks, that is mainly the 14 days, are very important when you talk about the suturolysis or injecting the 5-FUs. Once you lose that time period of 2 to 3 weeks, then 5-FUs or doing ALS may not be of much help to your patient. That is also important. So time already important. Yes.
Very true. And one more point, Dr. Shweta, like those who are dealing with this failure of trapped cases, always remember in the initial days when you feel there is a low height bleb, try for the digital massage, and you feel the bleb height is increasing. It means now you need to do the suturolysis because your bleb height is going to increase. And if you remove the resistance, then do the suturolysis. It will further help in survival of your bleb.
Yes.
Yeah, so it is very important.
Yes. And also just one point here, that never go for suturolysis for more than 1 sutures at a time, at a single sitting. That's a very important take.
Yes, very, very important. Very well mentioned point. And this is also very important when you feel there is a low height bleb. So you have to settle down the inflammation, increase the steroid frequency of steroid of the topical steroid, so that you can deal with the decrease in the inflammation, which can further help fight with the fibrosis.
Yes.
So I think that was a wonderful takeover, that we have to be very, very careful and vigilant, especially regarding steroids. We need to give slightly longer steroids to all our operated glaucoma patients, because we don't want the scarring and fibrosis of bleb to ensue. And definitely 5-FU and mitomycin C, they are actually a savior of our blebs. And whenever we have a complicated case like that Shweta showed us, we can definitely manage it. And if there is an issue, we can refer it to Shweta.
Sure.
So, Dr. Mukesh, your points were very valid, and thank you so much for all your points. And we will move on to next presentation because we have quite a lot of
Thank
excellent
you, ma'am.
expert faculty lined up. So we have next with us Dr. Vineet Sahgal, who is a glaucoma expert from Delhi. He is an RP Center alumni and doing excellent work, and not just doing the work, but also teaching a lot of postgraduate students, making them aware of the not just about glaucoma, but about cataract, about different specialities. So we have Dr. Vineet Sahgal with us. Welcome, Dr. Vineet. And then we have, as expert of the panel, we have Dr. Ruby Mehrotra. She is a professor from Lucknow and an excellent orator. And she's my senior also, very intelligent. And as an academician, she is wonderful. So we welcome you, Dr. Ruby, as an expert.
Thank
I
you
will
so much,
request,
Dr. Thank you,
I will
Shalini, for your kind words.
Thank you, ma'am, for joining us. So, Dr. Vineet, I will request you to go ahead with your presentation. You are muted, Dr. Vineet.
So thank you very much, ma'am. Am I audible?
Yes,
You're
yes, you are
audible.
audible.
Yeah.
Matlab, it's a such a matter of pride that you have invited me, and I would say that I am the junior most in this hierarchy, and मैं as a resident or as a teacher or as a glaucoma consultant, मुझे किन किन चीज़ों में ध्यान रखता हूँ, क्या क्या चीज़ मैं एक जनरल ओपीडी में मेरे पास अगर पेशेंट्स आते हैं तो मैं मुझे कहाँ पे लगता है कि मेरे पास कुछ रोड ब्लॉक्स हैं और मुझे उनसे कैसे ऊपर जाना है. तो आई वुड बी जस्ट very briefly telling about three very common case scenarios that we see in our practice. So the first case one, roadblock. मेरा जो आज का टॉपिक है वो है roadblock. So first roadblock क्या है? So we have a cataract patient. We all are very fond of seeing a cataract. मोतिया सबको अच्छा लगता है, but sometimes what happens is कि the eye pressures are high. So there is a mild to moderate glaucoma. The angles are open इस तरह से आप देख सकते हैं. So you want to do a cataract surgery. You want to basically increase the vision of the patient. लेकिन क्या हम इसमें और भी कुछ कर सकते हैं? Let's say patient is not basically they're having advanced glaucoma. So something which is right now in our armamentarium is a bank. सो वेरी कॉस्ट इफेक्टिव. हमारे पास आई स्टैंड्स हैं, KDBs हैं, बट आई वुड से कि एक 26 गेज नीडल दैट ओनली कॉस्ट 2 to 3 रुपीज इज अ वंडरफुल थिंग. तो एक बेसिक फिजियोलॉजी पे आते हैं, हम अपने बेसिक्स पे आते हैं जो हम लोगों ने MBBS में और MS में सीखा था कि अगर हमें ट्रेबेक्युलर मैशवर्क दिख रहा है, हमें नेजल ट्रेबेक्युलर मैशवर्क दिख रहा है और उसके बाद भी हमारा IOP जो है वो हाई है, सो व्हाट वी कैन डू इज वी कैन डिक्रीज द resistance to the outflow. And how we can do it? We can do it with the help of a 26 gauge needle. So एक small video है, that is first of all what we need to know is the positioning. तो positioning बहुत important है. I'm not going into too much details of how to do a mixed procedure, but सबसे important है कि positioning of the patient को opposite रखना है, microscope को अपनी तरफ tilt करना है. उसके बाद सेकंड चीज जो आपके लिए इंपॉर्टेंट है, डू अ लॉट ऑफ गोनियोस्कोपी. व्हेन यू डू अ बैंक, आपके पास एक 26 गेज नीडल है, उसको आपने इस तरह से बेंड कर दिया 70 to 80 डिग्री एंगल पे, एंड देन इट कैन बी यूज्ड टू डू अ गोनियोटमी. सो इस तरह से हमने नीडल को बेंड किया. बहुत इंपॉर्टेंट है कि आपको गोनियोस्कोपी करनी है. सो एनी MIGS प्रोसीजर, द वेरी इंपॉर्टेंट थिंग इज टू डू अ गोनियोस्कोपी. आपने एक डायरेक्ट गोनियोस्कोप लगाया एंड विजुअलाइज योर एंगल्स. यू कैन बेसिकली प्रैक्टिस इन योर कैटरेक्ट सर्जरी ऑल्सो टू सी अ लॉट ऑफ एंगल्स. एंगल्स दिखे, अंदर गए, इंपॉर्टेंट है क्लियर कॉर्नियल इंसिजन हो जिससे बहुत ज्यादा ब्लीडिंग ना हो आपके पास. जस्ट अ मिनट, आई थिंक वी जस्ट लॉस्ट द, हाँ, जिससे हम अंदर गए, हमारे पास कोई ब्लीडिंग ना हो, एंड वी जस्ट गो इनसाइड एंड एक्सरसाइज द your trabecular meshwork. So how much we exercise? We usually exercise 2 to 3 clock hours. We can exercise up to 4 clock hours, but not more than that. Remember, it's not a GAT, so don't go for 180 degree of that of excisional goniotomy. And after doing this, after doing excisional goniotomy, very important is to do a good visco wash for the patient. So this is my case one, Shalini ma'am. So the second case which we feel is that sometimes we do a very good ट्रेबेक्युलेक्टमी, बट ट्रेबेक्युलेक्टमी इज अ सर्जरी जिसमें आपको हमेशा लाइफ लॉन्ग उसको देखना है. सो जब मैं हर्ष सर के साथ था, मैं अपनी फेलोशिप कर रहा था, तो हर्ष सर हमेशा कहते थे कि ऑलवेज प्रे बिफोर यू गो टू द OT and always pray after you come from the OT as well. So trabeculectomy is a surgery, 30% is done in the OT and 70% is the post-op. So sometimes everything is fine, but 3 years 4 years down the line आपके पास patient आता है कुछ इस तरह से photograph दिखती है and there is a overhanging bleb. So what you have to do, you have to basically do a bleb repair. क्यों? Because such a overhanging bleb, this would basically cause blockage to the vision. It would basically hamper your tear flow, but सबसे important है, it can be a potential site for your infection or perforation. So what you do is you reshape the bleb, and when you reshape the bleb, the function would be preserved and the comfort would be restored, and you would be going to the sleep without any hiccups as well. सो एक छोटी सी वीडियो है. सो व्हाट वी डू इज वी बेसिकली एक्सरसाइज द ब्लेब. सो सबसे पहले जैसे टेरिजियम में हम करते हैं, तो उसी तरह से आपका अटैचमेंट है ओवरहैंगिंग ब्लेब का कॉर्निया में, आपने उसको एक्सरसाइज कर दिया. एंड एक्सरसाइज करने के बाद आपने जो एजेस हैं, एजेस ऑफ द ब्लेब है, उनको फ्रेशन किया. देखिए, कभी भी आप कोई चीज लगाएंगे, कोई भी नई चीज आप ब्लेब के ऊपर लगाएंगे, ऑलरेडी आपने माइटोमाइसिन सी लगाया हुआ है वहां पर, तो आपको ये बहुत इंपॉर्टेंट है कि उस ग्राफ्ट को अपटेक करना है. फिर आपने क्या किया, लाइक अ टेरिजियम आप नीचे गए, नीचे आपने एक हेल्दी कंजंक्टाइवा ली, आपने उस कंजंक्टाइवा और टेनिन कॉम्प्लेक्स को जो है एक्सरसाइज किया, और एक्सरसाइज करके लाइक योर डू अ टेरिजियम सर्जरी आपने उसको ऑटोग्राफ्ट किया और वहां पर उसको सूचर कर दिया. सो बहुत इंपॉर्टेंट चीज है ये कि आपने ऑलवेज कवर इट. एंड अगर आपको लगता है कि वहां पर नेक्रोटिक स्क्लेरा है या फिर आपकी एपिथेलियम डिब्राइडेड है, सो यू शुड हैव अ पैच ग्राफ्ट विद यू ऑल्सो, क्योंकि हो सकता है कि वहां पे स्क्लेरल नेक्रोसिस हो और आपको उस जगह को रीइंफोर्स करना पड़े. सो दिस इज माई केस टू, एंड आई वुड बी गोइंग टू माई थर्ड केस, जो कि मेरे ख्याल से श्वेता मैम ने बहुत अच्छे से बताया. एंड मेरे पास कोई और नई चीज नहीं है बताने के लिए, एक्सेप्ट कि जब भी आप जो है नीडलिंग करने जाएं, प्लीज टेक अ कंसेंट फॉर्म, बिकॉज वी आर हम लोग जैसे प्राइवेट सेक्टर में हैं, तो पेशेंट कहेगा डॉक्टर साहब बार बार आप OT में ले जाते हो, और अगर आपने नीडलिंग करी, नीडलिंग के बाद भी उसका प्रेशर्स कम नहीं हुए, आपको कंसेंट लेनी है. सो आपको बताना है, पेशेंट को एक्सप्लेन करना है कि सर मैं ये अंदर जा तो रहा हूं, लेकिन हो सकता है ये काम करे, हो सकता है ये काम ना भी करे. और बहुत इंपॉर्टेंट है, कल हमारे GSI ग्रुप में मेरी एक और मेंटर हैं कीर्ति सिंह मैम, एंड शी इज़ अ वंडरफुल टीचर एज वेल एज ग्लोकोमा स्पेशलिस्ट. और उन्होंने बताया कि अगर हमारे पास एनकैप्सुलेटेड AGVs हैं, हमने अहमद ग्लोकोमा वेल्व किया, उसके बाद प्रेशर्स हायर साइड पे हैं, तो यू कैन डू अ नीडलिंग देयर ऑल्सो. सो जस्ट मेरा एक पॉइंट है, ब्रेक द स्कार, रीस्टार्ट फिल्ट्रेशन. दैट इज वॉट इज देयर in your patient where you do want to do a needling. I think this is the video. So same points जैसे मैम ने बताया, we go inside with the 26 gauge needle. अगर 5 fluorosil 5 FU नहीं है, तो you can take a mitomycin C as well and go inside with that mitomycin C injection as well. Important है, अंदर जाना है, आपको ये प्रैक्टिस करनी है कि जो भी फाइब्रोटिक स्ट्रैंड्स हैं आपको उनको काटना है. सब स्क्लेरली भी आप जाइए और वहां पर भी जो है नीडलिंग करिए, जिससे कोशिश करिए कि आप अंदर जाके उस ब्लेब को रिफॉर्म करें. So with this, I end my presentation, and my last slide would be that glaucoma management is problem solving. It's not always a new surgery. Sometimes it's just removing the roadblock. Thank you, ma'am. Thank you very much.
Excellent presentation, Dr. Vineet. And very well, the videos were very well documenting the surgery, especially the one where you were showing the overhanging black part, and the way simplified and letting know about how to dissect, just like it's very informative for especially the residents who are there on this group, the way you dissected the conjunctiva, the way you very easily and clearly just demonstrated the dissection. And just one important thing that needs to be known, and especially for the youngsters who are there, that it is very important to decide what cases are good for surgery, number one. And
Very important, ma'am.
yes, and who are the cases who are at higher risk of complications with bleb. which is only evident if you're taking a very proper history. For example, if the patient is a little younger, number one, if the patient has undergone already some sort of ocular surface surgery, then these patients, I believe, are more at higher risk of, or there is higher risk of some complication which might be encountered. So, just small precautions like starting preoperatively with mild doses of steroid
Okay,
in
ma'am.
those patients topically can go a
Definitely.
long way.
हाँ,
Use
ma'am.
of these drugs, the antifibrotic, the mitomycin C, it
Yes,
is
ma'am.
helpful definitely. So we need to first preoperatively evaluate the patient so that it can reduce the chances of risk, if I'm not wrong.
डेफिनेटली मैम। मैम एक और चीज़ थी जो रेजिडेंट्स हैं, यंग डॉक्टर्स हैं, देख रहे हैं। मैं मेरे मेंटर हैं, इज़ लाइक अ फादर फिगर टू मी एंड आई थिंक एवरीवन नोज हिम, हर्ष कुमार सर, जिनके
Yes, all
जिनकी
of
सब
us know
चीज़ें
him
हैं।
definitely.
तो सर क्या करते थे, सर कहते थे कि पेशेंट को हम एक विगामॉक्स दे देते थे, जब एक मॉक्सीफ्लॉक्सासिन आई ड्रॉप, क्योंकि बहुत दूर दूर से पेशेंट आते हैं, आप दोबारा आ पाते हैं, और उसके उसमें एक आरएसवीपी लिख देते थे कि अगर पेशेंट में कोई, उसको लगता है कि कोई रेडनेस हो रही है या फिर कोई स्वेलिंग है या फिर विजन डिक्रीज हुई है या पेन हुई है, तो आप अगर नहीं भी आ पा रहे हो, वैसे तो कोशिश करो इमीडिएटली आओ, बट अगर नहीं आ पा रहे हो तो एटलीस्ट दिन में 3-4 बार इसको जरूर डाल लो। तो रूबी मैम, आई बेसिकली 100% एग्री विद यू कि पेशेंट को एजुकेट करना ग्लोकोमा सर्जरी के बाद वो और भी ज़्यादा इंपॉर्टेंट है एक सर्जरी से करने में, क्योंकि अब सर्जरी तो हम कर देते हैं, बट कई बार जो प्रॉब्लम्स शुरू होती हैं वो बाद में शुरू होती हैं। सो आई टेक योर पॉइंट। एंड सेकंड थिंग इज कि आजकल MIGS बहुत ज़्यादा चल रहा है। We still have to see the cost benefit ratio as well. So we are having doing eye stands, we are doing KDBs, but इवन कई बार इंश्योरेंस में कवर्ड होते हैं, बट हमें ये भी देखना है इंश्योरेंस भी 5 lakhs की होती है मोस्टली इंडियंस में। कहीं उसको कोई हार्ट की प्रॉब्लम हो गई, उसको ज़्यादा वहाँ पे लगा, पता चला 2 लाख का हमारा कोई और ही डिवाइस हमने यूज़ कर लिया। सो वेन एवर यू डू अ सर्जरी फॉर द पेशेंट, लुक एट हिज पॉकेट ऑल्सो कि क्या वो अफोर्ड कर पाएगा या नहीं कर पाएगा, हाउ मच इज़ द कॉस्ट बेनिफिट रेशो। इसलिए इनिशियली मैं रिकमेंड करूंगा कि बहुत इंपॉर्टेंट है कि यू शुड नो इंटर ऑपरेटिव गोनियोस्कोपी एंड डू अ बैंग गोनियोटमी, बिकॉज वेरी मच कॉस्ट इफेक्टिव। अगर जो है, क्योंकि ये भी पेशेंट्स होते हैं कई बार रिस्पॉन्ड करते हैं, कई बार रिस्पॉन्ड नहीं करते हैं, तो इंट्रा ऑपरेटिव गोनियोस्कोपी आना इंपॉर्टेंट है, और उसके लिए OPD में गोनियोस्कोपी करना और भी
Exactly.
इंपॉर्टेंट है।
Pre-operate,
तो
exactly. I will 100% agree, Dr. Vineet, that residents should practice gonioscopy in the OPD prior to getting accustomed to the intraoperative gonioscopy. And one very important thing that they should not miss is that sometimes, despite treatment with anti-glaucoma drugs, despite surgery, there are conditions when the optic nerve continues to get. So, a history of drugs, whatever drugs, because hypertension is a common risk factor, and there are many antihypertensives which are reducing the ocular perfusion. Despite a good surgery, despite good IOP control, sometimes it happens, still there's continuous loss of the optic nerve head,
yes, ma'am.
nerve fiber layer. So history, a meticulous history of the drug intake of the patient. There are beta blockers, the oral beta
Yes,
blockers, and the diuretics which can reduce. And mix, yes, there are good roles, but then there are certain constraints to it. It is not going to work in advanced cases, but yes, it is the need. Very nice presentation, and I would like to thank Shalini, Dr. Abhishek, and all the team to provide us with the opportunity to be a part of such a excellent academic program.
Thank you, ma'am. Thank you, Shalini, ma'am.
Thank you so much, Dr. Vineet. That was amazing presentation, and the roadblocks, you cleared all the roadblocks for all the forthcoming generation. That was amazing. And Dr. Ruby ma'am, your points were extremely well taken, and that shows how much experience you have in managing all such patients. And I'm so thankful to both of you for joining us. We have Dr.
Pleasure is
Anil
always mine.
Srivastava sir with us, who is chairperson of today's program. I will request him to say a few words. Dr. Anil Srivastava sir. He is also co-chairman scientific committee of UP State Ophthalmic Society. एंड बाकी तो सर इतने अच्छे सर्जन हैं, वो सभी को पता है। आपकी आवाज नहीं आ रही है सर। नहीं आ रही है sir. Voice is not coming. I think Dr. Anil sir की अभी आवाज नहीं आ रही है, तो in the meantime we move on to next presentation. So we have another very young, energetic, dynamic surgeon coming up with an excellent presentation, Dr. Ankit Agrawal, who is from Prayagraj and who will be talking about Argentinian flag sign, which we tend to see many a times in patients which are hypermature, having hypermature cataract. And the expert for this particular video is Dr. Shobit Mehrotra. And we know he is a prolific cataract surgeon doing excellent surgery from Ottawa. And we are fortunate to have this time today in this webinar. So with this, I will request Dr. Ankit to showcase his video presentation. Dr. Ankit Agrawal.
First of all, I would like to thank Shalini ma'am and whole UPSOS team for giving this wonderful opportunity to a young surgeon like me. So this is the video. So when we are young, when we have just started our practice, we all read this complication. We have heard about it in our PG times. And in my recoil, many PGs get mature and hypermature cataracts to get to operate. And as soon as we put a nick on the capsule, this is what it happens. And this is the classical Argentina flag sign. Another case, this is the video by Dr. Spandau. It's from YouTube. So basically why it happens? It's because the intralentricular pressure is much more than the pressure which is there in the AC. Now, once the Argentina flag sign occurs, we should not panic. First, fill the AC with viscoelastics. Then, using a capsule scissors, a microaxis scissors, and a microaxis forceps or a Haldipurkas forceps, we can just make a nick and try to make a rexis-like thing with the two flaps. Now, once this rexis sort of rexis is achieved, we can do the phaco in low parameters. Another case is this, where it's not a total Argentina flag actually. So when doing the rexis, here I was not using my usual microaxis forceps. I was using a Haldipurkas forceps. And you can see that there is a lot of viscoelastic leakage from the side port. So the mistake which I did here was not filling the AC again with viscoelastic to keep the pressure high. And thus, I was not able to rotate it back and it went out like this. So to prevent it running out from the opposite side, I made a nick on the opposite side. And this will even out the lenticular pressure and rescue the rexis from going beyond the equator. Now, making a small nick here using my scissors. Rexis-like thing is achieved. This is the video by Dr. Pradeep Mohanta. Here, he has done phacoemulsification in a young patient in which Argentina flag sign has occurred. So this patient is 11 years old, and as soon as he made a nick on the capsule, the Argentina flag has occurred. Now, it is very important to stain the capsule properly in all cases of hypermature cataracts. It will allow us good visualization. Also, in case of rexis around, it will be easier to complete the remaining part of the rexis as we can see the flaps properly. Now, first important is do not panic. Fill the AC again with viscoelastic and make a flap like this. The additional step what is done by sir is debulking the nucleus, reducing the intraventricular pressure here. Thus, this will help prevent the rexus from running out from the equator. And now he will complete the rexus. Now this will help in doing the phaco in a nice manner. Here it was a very small, young 11-year-old child. So actually no phaco power was needed and only IA was required to aspirate all the nuclei as well as cortical matter. Now we can examine the posterior capsule. It is fully intact. So we can put the IOL, single piece IOL also in the bag and keep the haptics on the sides where the rexus is intact. And this will support the IOL properly with no major decentration issues. Now, this is my case in which the capsule rexus has run out. So this was a case which I did some 3-4 years back in 2021-22. So in those times, a lot of post-COVID hypermature cataracts were coming because these patients were afraid to come to hospitals for the two years, and they had a lot of hypermature cataracts with a lot of fluid buildup in the lens capsule. And as soon as I tried to, I do double rexus to prevent this, but when I tried to increase the rexus size, it ran out. So here the rexus has run out. So what I'll do here is I'll try to put the nick on the opposite side and try to complete the rexus from here. And I'll cut this free floating flap. Now, because it's a semi-hard nucleus, I'm using viscoat here in the AC. I'll pull the nucleus in the AC from the bag because I was fairly young at that time. I was not confident doing phacoemulsification in the bag in a compromised rexus. And I did the phaco in the AC in this. Meanwhile, keep putting viscoat in the AC to prevent endothelial damage. And we can see that there are some air bubbles in the AC. And you'll see that during the whole surgery, the bubble which is there in front of the lens capsule lens will not get disturbed at all. Thus, it confirms that I have not touched the anterior capsule at all during the whole surgery. And endothelium during the whole surgery. So this is the edited video. I am putting viscoat again and again in the AC after every 15-20 seconds to prevent endothelial damage. Now using IA, I clear out the remaining cortical matter. I can see that the posterior capsule is okay. And I'll just put a single piece IOL in the bag with the haptics in the intact rexus region, that is horizontally. This patient did very well and had a good vision of 6/9 at 1 week post-op. Thank you.
Excellent presentation, Dr. Ankit. And I must congratulate you on the last part of your surgery, where you beautifully managed the hard nucleus, and the outcome came out to be very good. And intermittent cataract is a day in, day out cases we see in our OPD every day. And before going to the surgery, if we spend just 2 minutes extra during slit line examination, the OPD, we can make out whether the patient is having intralenticular pressure or not. And we can plan from the OPD itself before going to the OR whether people is dilating or not, how is the ACD, whether it's very shallow, and we can also see the health of the zonules before going to the surgery. And one thing I always do and I've learned over the years is we give mannitol before the surgery so that some of the interlenticular pressure and vitreous pressure also reduces, which helps us in managing these type of cataracts very well. In before after doing during surgery, uh, before hurriedly going into the further axis, it's always better to slowly proceed each and every step. We have to make incision properly. We have to take little bit of 2 second extra so the incision is proper, not short length or very long incision, so that it will help us maintain the chamber and also the post-op recovery of the vision. And rather than starting the rexes in a instant, it's always better to give a nick to the in the center of the capsule, and we can use the syringe to take out the decompress the capsule by it by pulling it through the syringe. And also high molecular weight viscoelastic also plays a very good role in managing such cases, and not only in the center of the AC but also the periphery of the AC. If we decompress and inject a lot of and repeated injection of high molecular weight viscoelastic, it helps to control the Argentina flex signs. And it's the way you were trying to do two-stage rexes is always better and also gives very good result in such cases of intumescent cataract which had tendency to run out. And there are many ways we can manage rexes, even spiral rexes in where the interlenticular pressure has been managed. And also sometimes when it's not possible to decompress with the help of our hydrodissection cannula, we can always go to for by manual indication aspiration for decompression. Once the decompression is done and the rexus is made in the second sitting, half the battle is won. We can always manage the nucleus, which is most of the time not very hard all the time. And then we can always plan the IOL in the bag. Until unless bag is compromised, we can always go for the in the bag implantation. The only thing which I want to say for Argentina flag sign is not a complication, it's just a warning sign. If we respect the capsule and we decompress early, you'll always get a good result.
Another thing we can do in the OPD, sir, is actually doing an anterior segment OCT from the lens capsule.
Yes, exactly.
You can see some vacuoles behind the IOL if it is there.
Yes, we could do, and there are reports of people doing YAG capsulotomy for the anterior capsule, but it's not a very safe procedure because we cannot see the outcome of the.
We cannot control it, sir. Sometimes it may not be YAG.
It's uncontrolled, yeah.
So I think that was an excellent presentation, Dr. Ankit. And you showed so many techniques how to manage these cases so well. And of course, Dr. Shobit, your take home was very, really too good for everybody, even for beginners and even for stalwarts. So thank you so much for joining today. We had Dr. Vinod Arora, sir, who is an excellent phacosurgeon from Dehradun. I would like to request his a quick comment and followed by Dr. Anil Srivastava, sir.
I think it's a very good presentation and perfectly it covered all the aspects of doing surgery in such cases. But I think it's better to prevent such conditions.
Right.
So for preventing Argentine flex sign, Either there are many ways people have described so many things. Just like making incision on the peripheral side, where the capsule is thicker, is much easier than putting your needle in the center. That's one of the tip I think is very, very important. If you make the incision on the mid periphery or periphery, then gradually extend it, then it makes very easy things going to do. We lost the voice, I think.
You're not audible, sir. Anil said not audible.
Dr. Anil, you have to unmute yourself. You're muted.
Now I'm audible. Okay. So, thank you, Dr. Salni, for arranging such a great program. And I welcome Dr. Vinod Arora, Dr. Kirti Singh, and it's a real honor to have them in our program. Regarding the capsule management in this condition, all the eminent speakers have told good points. But basic thing is how to prevent it. For prevention, the lenticular pressure has to be reduced from all blocks. Sometimes there are multiple pockets of lenticular pressures. That is why when you successfully go almost completing 70% and you enter in that triangle where there is one pocket of high pressure, and from that point it starts running. So my point is that it should be massaged gently to make all the pockets into single pool, and then you can suck it easily to make the pressure lower side. Thank you. We're running short, so we can go ahead for the next topic.
If I could make one small comment, I joined late, but we do a lot of these cataracts. If time permits, Dr. Shalini.
Sure.
Okay, so we have recently started following Dr. Kakadi and doing that YAG. I've done around 3-4 cases. To my surprise, it wasn't a dot. We did with a single mode 1.5 millijoules in the center because that's where the AC is deeper. We did an ASOCT pre and post, and we found that the thing flattened. But we found a little, linear cut. If even with a single mode, it was a linear cut. What we do most often is a baby rexus. I don't know if that was described, and that works more. And I find, Dr. Anil, that milking causes problems in my hands. So I just do a baby rexus. Once the rexus is complete, only then I go for a milking, not at before stage.
Okay, ma'am.
Nice takeaway, Dr. Vinod Arora sir, Dr. Anil sir, and Dr. Kirti ma'am. So I know this is an excellent topic, and we get to see so many of these cases. And everybody has his own experience to share. But because we have several more presentations from stalwarts, so we'll move on to next. And we are so thankful to you, Dr. Kirti ma'am, for joining us. We all know she has been director of GNEC. She is an excellent glaucoma surgeon, excellent teacher, and mentor to all of us. So, ma'am, we welcome you in this webinar. And she is talking about an extremely pertinent topic, which is aqueous misdirection. And to tell about the as an expert panel, we have another stalwart of glaucoma, Dr. Madhu Bhadoria, ma'am. We know she is an excellent, prolific glaucoma surgeon. She transformed the Sitapur Eye Hospital in an amazing way. So we welcome both the glaucoma experts to this webinar, and I will request Dr. Kirti, ma'am, to kindly start her presentation.
Is my slide visible?
Yes, Kirti.
So I have made it into video format. Is it audible?
Yep.
Okay.
Ma'am, we can't hear you. We are seeing the presentation.
The audio is there in the. Okay.
It is playing a video, which is.
I have made it into a video with the audio. No, you can't hear it?
No, ma'am, we can't hear that.
Okay, just
Ma'am,
a
it's
minute.
on mute. Your VLC player can. Yes, ma'am. Yes, ma'am. Increase the volume over there. Right side. Yes, ma'am.
I have increased to 106%.
Yes,
Okay.
ma'am. And in the left side, the red thing can be seen now. You
Huh?
click on that volume button. No, no.
Either?
Yeah, here. Yes, ma'am.
Okay. Now it's okay?
No.
Not yet.
Shalini, maybe, sorry, Kirti,
Now can you hear it?
no.
Okay, I'll speak it out then.
Yeah, that's what I was.
Started. So this patient operated trabeculectomy 10 years ago. She had phacoemulsification done. Post surgery, she had recurrent episodes of shallow AC with high pressures, medically managed. Third episode, the bleb was shallow, PI was up down, and the sclerostomy was blocked. Okay.
Take the volume higher, Kirti, maybe it will be audible.
Is my now I can hear you can hear me?
Yeah.
So first we did a YAG hyalotomy, then we did a Chandler's procedure with the vitreous tap with 26 gauge needle, AC formed. For some days it was fine. Then again the IOP increased. Then we did a 3-port vitrectomy with synecholysis, and then post vitrectomy vision recovered. IOP became mid-teens. We continued atoponization. This is the bleb which is visible. But after 6 to 8 weeks, her vision decreased for distance. She became a myopic, -4 diopters for decrease for distance and good near vision. Pressure again increased and the AC again shallowed. Then we did a iridozonulohyalod vitrectomy, IZHV, with a 23 gauge vitreous cutter through a surgical PI at 4,000 cuts, 350 vacuum. This was my first IZHV. And so we just did it from the anterior route with the simple vitreous cutter. And then I also reformed the chamber, and the PI kept getting blocked because of the atropine. And you can see the AC is it's formed. And after 2 years follow up, no recurrence, the AC is well formed, IOP is controlled. Other eye had a combined phacotrabeculectomy done, stable over 8 years since 2014. So we had both eyes behaving differently. Textbook revised in this malignant glaucoma. Our patients teach us most, and we did all the textbook techniques, but IZHV worked. Requesting your vote for member ARC North Zone as an academician who wishes to continue academics. Thank you very much.
That was
So
in
this was in case of malignant glaucoma where we did all the 3 procedures, including atroponization, and this is how it worked.
right, ma'am. So that is why it is known as malignant. So when we were postgraduate, when we heard of malignant
But
glaucoma, we
textbook
thought,
revised, it just brought us back to all the textbook procedures, halotomy, YAG laser, then Chandler's, and then, vitrectomy. I thought vitrectomy, it's done, but it didn't. Then I said HV worked.
right, ma'am. So that is why initially we thought that it is malignant because it is related to some malignancy. Then we realized no, 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 it is not. So I think that was an amazing presentation, and in fact, it is so difficult to manage these kind of cases many a times. So we have Dr. Madhu Bhadoria madam with us. I will request her to say her expert comment.
Kirti, before that, I want to know a few more things about the things. So, like, did you do a UBM and B scan, and what were the findings on that?
Ma'am, I was told by Shalini, ma'am, stick to 2 minutes. So
no, agreed. So, now it's a discussion. So
Ma'am, we did the ASOCT. UBM we had, but the probe is not very good, unfortunately, in our hospital. But we could show in the ASOCT, but that is not the investigation modality of choice. UBM is. But since we didn't have a very good picture, you saw the picture of the UBM. It wasn't a very nice picture. But that's what we have. And yes, we did a B scan. Of course, we did a B scan. First thing
So
we do
was the AL equal in both eyes, or was it different in 2 eyes?
Ma'am, say it again.
Axial length, was it equal in 2 eyes, or it was different in 2 eyes?
Ma'am, I don't remember now the axle length, but the patient had been operated for phaco years ago.
Yeah.
So
What I was
the
looking
IOL
at,
power was basically similar in both eyes, but as you know, most of our patients lose all the records when they come to us. Uh, I'm not very sure of my findings, but it was
correct.
similar. Yeah.
Okay, so like Kirti beautifully managed, it's an understatement because you did a great job with it. And you did all the procedures, they all have their own value. And sometimes I feel instead of being all that traumatic, we could just do 1/4 of the DLCP in these patients, because in most of these patients, there is rotation of ciliary body. So once the iris processes shrink, it is almost atraumatic, and as it is, there is glaucoma. So 90-degree doesn't really hurt that much. Other procedures you've already told, and the last thing that worked. Shirisha also presented multiple cases of this. Siddharth, Shirisha, one of them from LBP. There's a very good paper on it, and they found that this practically works in almost all the patients. So truly speaking, if the patient is a pseudophakic, then instead of a PPV, this is a procedure of choice, and maybe it's the first thing that should be resorted to, especially in your case that your idectomy and everything was shutting, it was pressure was so much was coming out. Maybe at the first stage also, like it was done as a first primary procedure also probably would have worked. So it's a really beautifully this thing and all that. But UBM and B-scan are both important, especially in ACG. In our country, in many, many patients, two eyes are pretty anomalous. They're not the same. The anterior segments are very different. One eye goes blind, one eye remains totally normal. So therefore, keeping that in mind, we got to really look at it with a different eye. That's why I was asking you that. Well, like, could it be that one of those kind of patients that who had one eye, anterior segment, a crowded anterior segment, or some kind of axillary body rotation? But since the eye was operated, it's obviously it's not a same eye. Like,
Yeah, ma'am, we saw it in a pseudophakic state. And
Yeah,
now,
so,
after
yeah.
this learning, as I said, these patients are our best teachers. So, this patient taught me a lot. She was a 70-year plus lady, and she was such a smiling lady. Each time she would come, कि मेरे को अब नजदीक का बहुत अच्छा दिख रहा है, दूर का नहीं दिख रहा. So, it was a learning for me also. Okay, myopia, alright, this happened. So, now, yes, ma'am, Dr. Vinita Pathak has also a beautiful paper on IZHV, as does Shirisha.
Yeah.
So, they have recommended, in fact, Vinita does a prophylactic IZHV now in the patients who have a shallower axil length. So now we don't do a prophylactic IZHV, but now whenever we have any malignant, I hope we don't have it, but whenever we have it, if it's a pseudophakic, it is my go-to procedure. And now after that first initial hesitancy, we find it easy to do. We just make a small PI at the temporal quadrant and do that vitrectomy. Initially, I was hesitant to do a temporal PI, but then there's a beautiful paper by Dr. George Spaeth on a temporal PI and ghosting, and in fact, he says a temporal PI may be better off. I'm not sure I agree with that because Caucasian eyes are different, but temporal eye is not something which is to be scared of. So I do a temporal PI, and from that do eyes at HB. It is, ma'am, now my go-to procedure.
Yes,
For malignant glaucoma.
really the procedure of choice.
The question I would like to ask you, ma'am, and the others is, for this patient, we did use atropine for 6 months before. After at 2 years, we kept using atropine. She would stop in between, and then for 2 years follow up, it was fine. Now she hasn't come back to me. I hope she's alive and healthy. How long do you advise atropine? Lifelong after IZHV also?
For life.
Even after IZHV?
Yes. For this somehow there's something that happens.
Somehow, even I think, what I had as young patient, he could not see the mobile phone and he would keep stopping the atropine. So what I did for him was I said, "Aap alternate day kar lo, 1 drop at night," because ointment was messy for him because he was dependent on his mobile phone for even his job. So he said, "Ma'am, main nahi kar sakta kaam." That was a 1-night patient, another malignant glaucoma. So we put him on atropine for lifelong, but we reduced the duration from not every day to alternate days, titrate. How about that, ma'am?
After HPV, you can use cyclopentolate because that is 24 hours. So that actually works better, especially in young people. That works as a better cycloplegic. It's a good cycloplegic, and mydriasis is not all that much. But atropine, of course, like the patient is elderly and all those who have got used to already a poor accommodation is fine. But for young people, cyclopentolate works better.
Yes, ma'am.
So I think that is an amazing take home that atropine for life. Of course, as many
Yes.
times we have seen that if we stop atropine, that tends to recur. So with this, because
I've seen 10 years also, Shani, after 10 years also to stop it like this.
right, ma'am. Thank you so much, ma'am, for your expert comment, and thank you, Dr. Kirti, ma'am, for an excellent presentation.
Thank you.
So
Thank you.
with this, we will move on to another very interesting presentation by another stalwart, Dr. Anand Parsarthi. And we know he is a prolific cataract and refractive surgery who has done more than 50,000 refractive surgery from Chennai. He has done 3 fellowship in the same field, one from Germany, another one from under Professor Donald Tang for Singapore, and then LVPI Hyderabad. So, Dr. Anand, we welcome you in this webinar. And to give expert comment, we have another very amazing surgeon from city of Nawabs, Lucknow, Dr. Bhartendu Agrawal, who is my senior also. And we have seen him performing excellent surgery. So we welcome you, Dr. Bhartendu, in this webinar. And I will request Dr. Anand Parsarthi to present his presentation on small pupils, which is many a times a challenge for young surgeons also, and also sometimes for experts. Dr. Anand, please.
Thank you, Shalini, for inviting me. And I must also tell you, I have a very super senior junior relationship with Dr. Baduria. I am from AFMC Pune,
Oh, wonderful.
my undergraduate.
Very nice.
And it is so lovely to see all of you in jackets and me in a shirt with my fan on. Because I'm in a different part of the country where I have temperatures of 25 degrees. So thank you so much, and I'll go to my presentation.
Very nice.
So I was asked to speak, and I decided that I'll just take basically a short experience of what we try and do with small pupils, and this is a very short presentation and a smaller part of what I have. But I guess there are now multiple options of trying to manage small pupils, including IRIX. But though, just to confirm, I don't have any financial disclosures, though it would be nice to have some in some of these that are mentioned. I guess when you mention small pupil, you do a perfect surgery, you end up with a round pupil. It's like achieving nirvana. And I guess that's an important part at the end of surgery to achieve. And we do have patients whom we do use iris, and you can make out post surgery the pupil is actually very irregular. You can see multiple sphincter tears in this patient who had a floppy iris, and iris hooks were used in this patient. Now, this is a video by Dr. Suven, and you can make out that if you can get a size of the pupil, do surgery, it can get messy because sometimes the iris hooks actually pull the. So it's a good idea to actually use five hooks, one under the main margin, and you can of course be careful. Now in this patient you can make out iris dialysis, aerodialysis also occurred. So it's sometimes not a very elegant procedure if you're using hooks, so you need to do the dilatation inside the eye, and that's probably the best way of doing it. Now whenever you have two types of pupils, one is the it's good to check the elasticity, and on the left you have where the pupil actually responds. So this is a stretchable pupil, but if you have slightly rigid ones like this which don't stretch, you're probably going to struggle, and you will end up with sphincter tears. And I'll tell you why this is important. But just small principles: long tight incisions, gentle slow hydrodissection, intracameral adrenaline, and of course you got to use low parameters. You've got to use the best viscoelastics available. And this is one patient with a pupil membrane, and sometimes just removing the membrane alone sometimes helps you go ahead with surgery. And in a lot of these patients, the cataract itself is not actually very hard. So with a combination of hooks or devices, you can actually complete the surgery with a standard phacoemulsification. And a lot of times, even if it's floppy, you could probably get away. And this is the patient I'd like to present, wherein we had a small pupil before we actually went ahead with the procedure. And in this, we are using the BHEX. And this is best. There are actually three versions: BHEX 1, 2.0, and now the Octa. Hex basically is for 6 points of contact on the pupil. And they have basically 3 parts that go under. So 6 means 3 parts that go under and 3 parts lying over. So the hooks basically go under, the ones with the holes. You can use special forceps as well. And the tricky part is the last part. Sometimes you got to actually, it tends to wobble a bit. So you have to be very, very careful in pulling this. It tends to fold over itself. So, but when you're actually doing this, and you can use a counter force, like I was just going to do it. But sometimes, if you're very lucky, you put a bit of visco under the pupil and lift it. It helps to kind of stabilize. And now you've got a 6 point of contact. This is after the lens insertion, because I was told I need to keep a very, very short video. And taking out is actually quite easy. You can do it from the side port or from the main port. So you just kind of nudge all out, or you can just nudge it under the phaco incision, and you can use either a McPherson or a standard forceps to remove it. So it's quite easy to insert, and definitely quite easy to, and you can make out the pupil doesn't have so many sphincter tears that usually do occur. So I won't touch upon this, but remember that intraoperative meiosis is unpredictable. There are multiple versions for this. So in conclusion, a successful surgical outcome can be achieved both with mechanical dilatation and iris retention, but iris retention is my preference. The retention devices definitely add to the overall surgical cost, but provide a very good option anytime during the surgery. Point of using, if you're putting it after the rexus, make sure that you're not catching the rexus. So that's an important point, either with a Y hook for visualization. And I was told to stick to 4 minutes, Shalini, and I've done that.
Thank you so much, sir. That was indeed an amazing presentation.
Dr. Anand, Shalini favors you. She told me 2 minutes. So you got 4 minutes. Good.
So I just wanted so that we can get crisp information regarding every procedure, and we can cover many topics. And that is why I'm sorry if I limited the duration of a talk. But I tell you, all of you are telling such amazing points, and I'm pretty confident that all the viewers, they would be full of appreciation, and they will definitely utilize all these tips in their day-to-day practice. We have Dr. Bhartendu Agrawal, sir. I will request him to kindly give his expert comment.
Yeah. Good evening. Thank you so very much for having me here. So it becomes the job of an expert comment very easy when you see such a lucid and complete presentation. Yeah.
I can't see you. I want to see you, Bhartendu.
Ma'am, I'm trying to come, but
yes.
I cannot see because what I see is one slide. I can't see myself actually.
No, I can see you. Anand, okay, stop sharing, please.
I'll just stop sharing.
Yeah.
Okay, great. So thank you, Dr. Anand, for a complete and a very nice presentation. You have completed almost everything and very little to really insert any points further. But just for the sake of repetition, few points. Just we have to anticipate meiosis during our whenever you go for a surgery. As you have rightly said, there are two kinds of practically pupils that we encounter during surgery. One is a rigid, another is a floppy kind of a thing. Dr. GC many years ago taught me how to recognize a rigid on a OT table. You just take a small Sinski and go to the opposite meridian and just tab it, and if the opposite meridian moves, it is not rigid, otherwise rigid. But it can easily be found out by putting in viscous and viscoelastic and various other maneuvers. Well, I have been, when I started my practice, and as a young person, I used to use a lot of hooks because there weren't many different kind of pupillary expansion devices available. But now you can choose anyone that you feel like. But in last 5, 7, 8 years, I've stopped using any kind of devices, because all of the devices will give some kind of a pupillary tear. So what I do, I use Kuglin hooks, and I create a little bit of a stretch pupilloplasty, especially in the rigid pupils, and if it becomes 5 millimeter or so, that's it. But there are a few exceptions where I would like to use some expansion devices, and then I use hooks or Mohan or anything which I get my hands on. I have no particular preference. In a patient where somebody is diabetic, or we want to do a posterior segment examination, actually mid-dilated 3 or 4 millimeter pupil really helps in posterior segment examination. As far as peroperative things are concerned, viscomydriasis, Dr. Usha taught us many years ago. Viscomydriasis really helps. Sometimes we see that a 4 millimeter pupil with the help of a good high molecular weight viscoelastic device, you can actually stretch it to 5.5 millimeter, and you can perform a rhexis, which is sometimes very challenging, but with little bit of dexterity and experience, you tend to make good rhexis even in 4 millimeter pupil as the time goes by. And once the rhexis is achieved, then a gentle hydrodissection, you tap it, you don't allow the pupil to snap on you again. Again, a dollop of viscoelastic, and with low parameters, you can complete most of the cases. But yeah, two very hard cases and all, one has to be very careful, and it is always a good idea to use these expansion devices. As far as intraoperative meiosis is concerned, where sometimes when you start a surgery, everything is fine. That becomes a challenging issue where one has to be very, very careful. Whichever pupillary expansion device you're using, you have to see whether you are taking a bite of rhexis inside that. So I have learned over the years from the masters that you just put in a small bit of visco bit underneath the iris, segment wise, and you just you can put in a spatula also from the opposite meridian, and with direct visualization, you can actually put in your device gradually so that you are sure that you have not taken a bite of rhexis. And thank you for all those lovely videos and beautiful slides, and we have learned a lot from your presentation. Thank you so very much.
Thank you. Great comments. Just probably an add-on, both in terms of I think for somebody like Bharatendra, who's extremely experienced, 5.45 would probably not make a difference. But when the pupil is small, what the challenge is to get an adequate rhexis. So I think there are two parts to the pupil. One is the type of the pupil. The second is the type of the cataract. A lot of times you have a bad combination of a small pupil and a hard cataract, where trying to do it with a small pupil and a small rhexis is probably an invitation to lead to some complication. So I tend to err on the terms of safety, to just make sure that you have the 6.5, 7 almost all the time, especially if you're not sure you will be able to take out all the cortex and then place the lens. A lot of times, especially in elderly, we have a subset of 80 plus patients who have purely dilating pupils. We have a very thick nucleus. The bag seems to be wobbly. So a lot of times you may need to do a CTR with a cataract removal and posterior and anterior optic capture, wherein the larger pupil beyond 6 will definitely help.
I entirely agree with you. If you see a patient where there are more than one risk factors, it is always a good idea to put in a expansion device. It is not that the heroism which I was suggesting. I was suggesting that many of the cases where the NS3 grade cataracts, after cataracts, where you can actually pull the nucleus out of the bag, and if that is the case, and there is a case where the very, very shallow AC and the nucleus is soft, you wouldn't like to venture, and cause irreparable or delayed visual healing by causing endothelial damage. The idea is that it can be done without pupillary expansion devices by Kuglins. I've been using it for many years. As far as the main reason that many surgeons feel that with all these expansion devices we are not causing tears. Of course, the tears will happen. The pupil will become little ugly, post-operative face. So why not cause it with the Uglan and save a day? But certainly it is not recommended. But as if you see more than one or two risk factors, depending upon the surgeon's comfort, I would always prefer safety over bravado. And the idea was that many rigid pupils can be actually dilated very nicely, especially post uveitic and pseudo exfoliations and many other kind of pupil. But yes, floppy is a dangerous realm that one has to be very, very careful of, because the stretching pupil is not recommended. And if it starts bellowing, and if you just catch it, and if you are not really comfortable, or you have not put the parameters correctly, because once you catch it, then you'll have it. So it's better to put in a safety valve in the form of anything of your choice. I have not used Octa, but I have seen your video and some other videos sent by Dr. Suven. It is phenomenal. I mean, the pupil really opens up like 6.5, and what is left for any kind of a surgeon to really show his talent, because 6.5 is really, really good. So yeah, safety first. I agree completely.
May I make a comment?
Yes, ma'am, sure.
Because we other glaucoma people, we very often deal with this band of pupil. And the other part is when the AC, I would agree with Dr. Anand, the type of cataract and the pupil size, and also the depth of the anterior chamber. Because again, in the government setup, we don't have that costly devices, we only have the iris retractors. And what I found is, if you add a little bit of intracameral xylocaine in addition to the visco, the pupil dilates a little bit more. Just for topical anesthesia, we're using ultra, no financial interest, whichever intracameral xylocaine without adrenaline, the pupil dilates a little bit more. So we add that with the visco. And one another tip, I don't know how many of you are using iris refractors, we are using it very frequently. The entrance, we make it just at the limbus, slightly scleral. So that doesn't make the iris gets pulled up towards, like that. And that really helps. To the iris then doesn't misbehave too much. And this other thing which I do, I'm not that the surgery amount of surgeries you guys do is phenomenal, but in those patients with glaucoma, patients with hard cataracts and small pupils, I prefer the traditional divide and conquer, because in that way you can divide the nucleus into 4 and then kind of tease it out very easily with even a small 6 millimeter pupil. So these are my little tips on, because we do this where we have it very frequently, the small pupil and the shallow AC and the angle closure glaucoma eyes.
Yeah, ma'am.
Shalini, may I?
Yeah. So what I was trying to suggest, that in all these cases, whenever you are approaching, it is the approach has to be tailor made. It might differ from you to me to some others, very excellent surgeons that I've seen. They can operate in 3 millimeters and get away. The point about intracameral xylocaine and adrenaline, once there is an intraoperative meiosis, then it hardly ever helps. That's my experiences. It may help in the beginning. Whenever you're making an incision, you put in the best possible dilatation that you have to get. You'll get it then and there only. But once you catch up, or once intraoperative meiosis takes place, then adrenaline and xylocaines, in my experience, it really doesn't work in every case. It may work in one odd case. And you rightly said that whenever you're using iris hooks, you don't have to make a sealed incision. It has to be a stab incision towards scleral side, because that is going to really hold. Because otherwise, if the intracorneal space is too long, it will have a overlocking effect kind of a thing, and you will not be able to achieve what you wish to achieve, because these has to be really stab incision and has to be really acute angles, so that it really catches the pupillary edge nicely, and you can actually stretch it as much as you like. That's a leeway that you can get with iris hooks most of the times.
Shalini, may I? There's one pupil.
Yes, ma'am. Sure, ma'am.
One pupil which is left uncovered thanks to our uveitis counterparts. Many times you will find a small pupil which is absolutely tightly wrapped by the pupillary membrane. So before you reach for any procedure, you got to cut that off, and it goes even behind the iris also. So that has to be rexed out before we can go on any kind of a pupillary procedure. So procedures have already been already talked. So that membranectomy is a very important part with the chronic uveitis patients.
Yeah, Dr. Anand showed one case where he has just removed the membrane and the pupil really opens up nicely.
Yes, yes, yes.
Yeah.
So we have more experts in phaco and meotic pupil. Would anybody else like to say a quick comment, and then we move on to next presentation?
I would like to make a comment.
Yes, sir, please.
Yeah, please. For the beginners, I think it's much easier to use iris hooks. And the tip is here, don't overstretch. It's better to place all the hooks first inside, then engage the pupillary margin. So that make it quite uniform. And most of the problems come with the overstretching. So don't stretch too much, make around 5 to 5.5 millimeter. And once you get good feel of this, then switch over to rings or other devices, whatever you want to use. So for the beginners, I think iris hook makes much more sense. And as far as the size of pupil is concerned, so for some people, what we call it is small pupil. It's a 2 millimeter, 3 millimeter, 4 millimeter, or 6 millimeter. So very well pointed out. It depends on the expertise of surgeon. It depends on the type of cataract we have got, and if there is any comorbidity associated with these things. So all these things make what is a small size. So we have to consider all the factors, and then we have to pre-plan whether we are going to dilate it or not. So these are the small tips we can do while doing a small pupil surgery.
We should not.
Yes, I think. Yes.
We should not be hesitant in dilating people, because you can do better justice when it is dilated for axis fixation or cortical removal. So better to use any expander, but don't expand too much. Thank you.
Yes, sir. Anybody else? Shashank?
I have just a small comment, ma'am.
Yes, Dr. Ankit, go ahead.
What I have learned in the last 5 years, expander should be the put first before doing rexis. Never try to put expander or hooks after doing rexis until you are actually very expert, because the rexis margin may get caught in the hook or the expander and may get torn. So that's an important tip for the beginners.
Right, very true.
One additional thing, we were initially in our residency, the youngsters will not have that aspect because you have all the options. We were taught to do a small sphincterotomies. When you don't have expanders or iris hooks or whatever, even if you do small sphincterotomies with the Vanna scissor in 4 quadrants, and then dial out, then do the rexes, it may work. In case you don't have any of these things, or it is costly and the patient is not affording, these small sphincterotomies also are effective.
Man, I would advocate Kuglans. I've given up sphincterotomies many years ago. Kuglans is really wonderful. You just have to try to believe it. It really obviates the need of.
It's the cost of the thing which is available, or availability.
Yeah,
we are a government setup and we don't have those. We only have iris hooks.
It's not very expensive if you take from one of the local vendors. It really doesn't cost much, 500-700 rupees a single. You just need a pair, and if you have a long Sinsky also, which is blunt in nature, you can actually stretch from that also. But making a sphincterotomy, I have never been a proponent of that. I have given up many years ago, ever since I've started using Kuglans, and obviously with various devices are not available. So it really saves your day. In most of the uveitic cataracts, tonic pupils, it really works well. It really stretches the pupil 5 or 6 millimeter many a times, and with viscomydriasis and added procedures, it really works well. Dr. Anand, I don't know whether anybody else has used Kuglans. I use it all the time.
Yeah, I think Kuglan and why is works. Coughlin, even if you have these Y hooks, which sometimes we see under the iris, that works equally well. Just a small point, because I've committed this mistake. What happened occasionally was when I was doing the stretch pupilloplasty, as I was stretching it, we nicked the rexus in the periphery, the capsule. So now that becomes a challenge, because now you need to actually make sure you include that in the rexus. So that is, you have to be extremely careful to make sure you lift the iris up. And I think these are good ideas. Coughlin definitely better than Y, but we for, I think, I don't know, for one reason I happened to use the Y on one end, and I was going towards 6 o'clock. I realized that I had nicked the capsule. So now that became a challenge, because that become a weaker area. So if you are doing it, definitely Coughlin or even for a ball dialer would work well. And ball dialer from the side ports would also give you that. But whenever you're going to the periphery, make sure you are above the plane of the capsule, because if you nick it, believe me, you will have to really make a very, very large axis to include all that torn areas. Not easy, and then your heart is in your mouth, because you're never sure when it will extend to the opposite side.
Yeah,
But Coughlin is a good idea, definitely, where you have a stretchable pupil. I would agree with Bharatendu on that.
Yeah, Coughlin is very safe. Actually, the stud is really blunt and round, so you can be sure when you're stretching that you'll not be damaging unless you really trying to.
I would agree with that part. Coughlin is a reasonable idea. When you are at the borderline, you don't want to open the hooks, you don't want to open this thing. It's not a bad idea, because you don't lose anything by stretching it and then putting in rings. Absolutely. So if you get that and get your visco, if you make a 4 into a 6, you may still be able to do the whole cataract without actually using devices.
Absolutely. That's the idea.
So I think that was an amazing discussion going on. And truly speaking, even the iris hooks, they are now extremely cheap, and we can get it from Indian vendors, and they work extremely well. So no need to go for very costly devices in case of there is restriction with regards to finances. But then we have amazing devices available. And in fact, BHEX, which is by Dr. Suvin, is an extremely wonderful device. And being our Indian inventor, we all should use it. And it works so well. And Dr. Anand showed us a wonderful video also.
I'll just mention the pricing, because I think that is something that it comes up in devices. See, when we started 10, 12 years back, we were using Malyugin ring. Those were expensive, 5,500 to 7,000 rupees, 10, 12 years back. Right. These days, the Gupta ring, it also stretches the pupil. It does give a very good size, and it is done by Dr. Gupta from the Madhu Instruments Group. But sometimes the pupil does go out of shape, and it looks very floppy at the end of surgery, but gives you almost a good 7mm area to work with. That's about 700 odd rupees. The Dr. Suven's ring is, I think, if you buy it in bulk, between 1,500 to 2,200 rupees. And if you take care of it, sometimes very occasionally you can ETO it and reuse it. Not ideal, but that is something that I know that some surgeons also do. So that, I think, in the range when you got 250, 500 rupees for hooks, to up to 1,800, 2,000 rupees for a Suven's ring, I think it's not a big add-on in terms of the cost. And at least in my part of the country, where 90% of our surgeries are insurance, you can actually get reimbursed for the rings, the BHEX rings, if you're using it.
Yep, true. So in place of Y, I have felt that even UPSOS dumbbell dialer is an option which can be used for stretch papilloplasty. And it's a very safe also, because it has a small dumbbell at the end, so it can never nick the anterior capsule. So that way it is a safer device. So
I think going forward, probably the reusable ones made of silicon. I think there's one by the Arvind group, and now I think Dr. Kakadi also was mentioning something wherein you can autoclave and reuse it, because the material is what is made in the silicon for your phaco sleeve. So you can actually autoclave it, so that recurring cost will come down very, very significantly. So I think reusable silicon pupillary dilating devices are now available, and it's a reasonable option. They're not very thick in profile, quite easy to insert and take out.
Yeah, I've seen the one made by Arvind. It looks pretty bulky. I've not used it. They gave me a few, but it looks pretty bulky. I don't know. If somebody has used it, they can share their experience. It comes by some Nova or some name. I can't.
Yeah, so it's called iNova ring. I have used it, and it's really difficult to put it even through a 2.8 incisions.
Oh my God.
Right, ma'am.
I had to increase it to 3.2 to put it and explant it. I maybe used the first edition because I used it like two and a half years back. Now the person came saying that we have improved on it. I don't know. I'll try it again and let you know.
So I think that was an amazing discussion and wonderful take-home message. But we have one more presentation left. So we are fortunate enough that Dr. Namrata Sharma ma'am has joined. She is traveling and because of delayed flight, she has joined just now. So thank you, ma'am, so much. And we all know very nicely about her. She is already chairman scientific committee AIOS, doing wonderful research, many publications, and today she will be talking about capsular back distension syndrome. And we know that this is a unique problem which happens sometimes with all of us. So let's see how to manage. And then we, as an expert, we have Dr. Vinod Arora from Dehradun, who is an excellent prolific cataract surgeon, and he will be giving his expert comment for the same. So we welcome Dr. Namrata Sharma ma'am for the presentation.
Thank you so much, Shalini, and I would like to thank Dr. Shalini Mohan and the UPSOS for inviting me today, and also for this unique theme of the webinar, which deals with the crisis management. I would be talking to you about capsular back distension syndrome, which can occur in some of the cases, and this was a case which was actually referred to us because of the myopia that the patient had. And despite the fact that there was intraocular lens which was present, single piece IOL, and there was notice also a phimotic ring which was present all around. So we did this under intraop OCT guided microscope, and in this you can see that there is a gap which is present between the posterior capsule as well as the posterior part of the intraocular lens. But before actually dealing with it, we have to first relieve the phimotic ring that is present. So first we inject the viscoelastic. Subsequently, after injecting the viscoelastic, we cut this, excise this fibrotic band which is present all around with the help of the micro forceps, and this could be ILM peeling forceps which is being used here, or it could be a dedicated micro forceps. So this comes out quite easily. There is nothing a big deal about it. And subsequently, after removing this, you can see that the bag becomes a little loose, and then the viscoelastic is aspirated going behind the lens. So this is the gap which is present, and earlier this was absolutely taut. Now this has become a little wrinkled, and after going behind the lens, the viscoelastic is aspirated. And after aspirating it, you'll notice that the intraocular lens would sit bang on to the posterior capsule. So this IOL will sit bang on the posterior capsule, and once that happens, again the aspiration is being done and the wound is hydrated, and you can see there is no gap between the IOL and the PC now. So this is it, and this is how it is tackled in this case, and other methods also can be used like YAG, capsulotomy, etc. to tackle this. And you can see that there is no gap present between the PC and the lens now. So thank you very much for your kind attention, and I just wanted to share this short video. I know that I'm standing between you and your dinner, so I will not take much time. Thank you.
Thank you, ma'am. That was an excellent presentation. And truly speaking, diagnosing this condition is also a challenge for some of the surgeons. So thank you so much for taking this up. I would request Dr. Vinod Arora, sir, to say a few his take on this particular syndrome. Do we have Dr. Vinod, sir, with us? I think he is not there. Anybody else would like to comment upon this particular situation? Any of the other experts? Dr. Anand, would you like to say something?
Sure. I think and fantastically managed, Namrata. Just probably a suggestion which we did there are a new set of lenses which are actually the optics are quite big. So this capsular distension does occur. Did you consider doing a peripheral YAG in these patients?
I think she's left because
Ma'am is left, I think.
she was about to catch her flight, and there was a delay in her flight.
My suggestion would be, because we did see a couple of patients now, there are some lenses which are having actually squared large optics, and if you're not careful with going behind the PC and doing a wash, you will end up with a bit of visco behind, and that does cause some amount of myopia. So I think the first clue is always the myopia. If you have, and second is, you'll see the back tends to sit more, the IOL tends to sit more anteriorly. The whole bag is kind of pushed forward. So AC appears shallow. The second point is, once you dilate, you can see the difference, the gap between IOL and the PC. Simple, very simple, and you can do a very low energy, like a 0.8, 0.9 YAG at 4 points in the periphery, and you can see the whole back. So I mean, the skill involved by what Namrata did is amazing, but I feel an OPT procedure a month down the line, just kind of 2 or 3 peripheral, very small point, 0.9 millijoule shots usually solves this equally well.
Yeah.
No, I would absolutely agree with Dr. Anand. We call this an anterior capsule, especially if there's a little bit of small rexes. This happens when the rexes is a little smaller and the bag kind of, says hello to you. The whole lens kind of says, it comes forward. And we just put four, five, I mean, 1, 2 to 3 shots, depending on where the bulge is more, and anterior rexes, you just puncture with an anterior defocus, not a posterior defocus to avoid the IOL pitting. You just do an anterior defocus and less than 1 millijoule shot, and 2-3 shots there and 2-3 shots there, like in a circular manner, and the thing starts flowing out and the bag settles. Because rather than do a surgical procedure, if a laser procedure works, absolutely. So the trick is to do an anterior defocus and a very small one, so that the IOL pitting doesn't happen.
Right. So as we were saying that prevention is always better. So implanting an IOL under irrigation is a very good idea, and I routinely do it in all my cases, and that actually helps a lot. There is no epic spikes in post-operative period. There is no inflammation, and surgery also finishes very quickly because we don't have to do visco wash. So implanting IOL under irrigation is another option which can be comfortably done, and that actually prevents such a situation also.
So meticulous visco cleaning, once you finish the case, just go behind the IOL. If you're not comfortable with bimanual or your coaxial, you can actually, after finishing the case, you can actually use your hydro cannula, just nudge a little bit of IOL, make the eyes soft, and you just go and wash it. It really helps really well. And because the main culprit is that visco is trapped, and as ma'am has rightly said, when the iris is, when the rexus is a little smaller as the newer generation IOL, especially the trifocals and all these IOLs, you would like to make a little small rexus for the complete coverage of the entire IOL optics. These are the cases where you would see that. And Dr. Shalini has said, but the margin of safety with hydro implantation, one has to be really, really very, very careful about the rotation, and when there's a turbulence inside the chamber, when you are trying to insufflate the bag with the help of a irrigation cannula. But yes, if you can master it, there's nothing like it. And all the speakers have rightly said that it was an overkill that we would take the patient to the OT and try and do a procedure where a very low energy YAG actually does a trick. I've done just one in practice of nearly 2 decades now, and it really works well. You can actually see the myopic shift withering away within few seconds. So it really works. But the prevention is the main key. If your rexus is smaller, and if you're not taking out the trapped viscoelastic from, it really can bother you.
I had something also different. I have not really faced a capsular extension back syndrome per se, but what I faced is a phimosis over some years, and there was a sommering ring types, days in the posterior capsule and between the IUL and the posterior capsule. In those situations, you may not get away just with a laser. In that case, you may have to do surgery and cut the phimosis, and then go behind and just lift up the IOL and suck away the because at that time what happens is the IOL is pretty much fixed, and rotation may break the bag. So I would say don't rotate, but just levitate the IOL edge from the rexus and just go behind and with the bimanual suck out the sommering rings. I don't know if anybody else has seen it, but it happens sometimes that the like a soap bubbles, they just accumulate behind the IOL. And have you seen silicone oil like that? Because silicone oil sometimes has a tendency to creep behind the IOL, even after silicone oil removal. I know I'm digressing, but any of you experts have seen that?
So coming to your first point, there are certain kinds of eyes which are predisposed for phimosis, as we know, pseudoexfoliation and high myopic eyes. They really the capsular phimosis really takes very it happens very fast. In one of my patients, I remember she was a high myopic lady. Actually, the phimosis took place so much that it actually contracted the peripheral haptics into a figure of 8. And within if I remember correctly, 2 or 3 weeks. So I took this patient to the YAG laser and anterior defocused and did 4 or 5 anterior capsulectomies with the help of the laser, and it really opened up nicely. So it was and obviously when the eye was it was strangulated within the bag, the phimosis it was so fulminant, and it came so rapidly. And actually, in the cases of pseudoexfoliation, it is extremely common. 3 months, 4, but it doesn't cause capsular distension syndrome per se, but it causes a bit of shift, and the quality of vision sometimes may go down. So I always make a larger rexus, let's say 5.5 or 6 millimeters, sometimes the cases of pseudoexfoliation by design, because I know that it's going to get shortened over a period of time. But I have not seen capsular distension syndrome, or rather, I may not have looked for it in pseudoexfoliation, but in my one case, I have seen one.
And silicone oil? Anybody has seen the silicone oil going behind the IOL?
I have not seen silicone oil going behind the IOL inside the bag, because mostly what I have seen is it comes from transzonular spaces. It comes inside the AC, which is very common. But bag is I have not seen.
I think that was an excellent webinar, an excellent discussion, and truly speaking, so much valid points were shared and transmitted via this webinar. So I feel very happy that the choice of faculty and experts was excellent. And I thank each one of you for having such a wonderful discussion. And it is definitely going to help everyone across with such cases and such crisis management. So thank you, everyone. And I will bid farewell to everyone and goodbye, and see you again with the new topics, new experts. And I would request everyone to join the webinar.
Thank you so much, and thanks for inviting me. Have a lovely evening.
Always a pleasure.
Thank you so very much.
Thank you, ma'am.
Thank you so much.
Thank you.
Thank you, Shalini. Thank you.
Thank you. It was truly wonderful. I also learned a lot. The problem is that however old you get, you still keep learning. The learning never stops. So
The
great to
quench.
have.
The quench.
It never stops. The learning never stops.
Thank you. Thank you, everyone. Good night.
Thank you.